Good morning, and thank you for the opportunity to present. We have nothing to disclose. In the United States, ventral hernia repair is one of the most common procedures performed by general surgeons, with greater than 350,000 performed annually. More advanced techniques, such as component separation and myofascial release, have been developed to address the relatively high reoccurrence rate associated with this disease process, and advanced high-volume hernia centers have been established to offer concentrated expertise in the United States. Readmission status is an important clinical and economic component of healthcare outcomes and has been studied for ventral hernia repairs. However, 90-day readmissions following open complex ventral hernia repair has not been well studied with national-level data in the United States. Therefore, the aim of our study was to compare readmission rates for patients undergoing open, standard versus complex ventral hernia repair at 90 days using the National Readmissions Database. We perform a retrospective cohort analysis evaluating open ventral hernia repair readmission rates by using the National Readmissions Database from 2013 to 2014. This database contains discharges from all payer sources and the uninsured from more than 2,000 hospitals in 22 states. Patients were selected from this database by using ICD-9 codes that corresponded with CPT codes for open ventral hernia repair with or without myocutaneous flap reconstruction. This table here shows the ICD-9 codes corresponding to standard and complex ventral hernia repair. Patients were considered to have undergone a complex ventral hernia repair if they had an ICD-9 code that identified any type of ventral hernia repair with an additional ICD-9 code of either of the bottom three codes listed in this table. All other patients were considered to have undergone standard ventral hernia repair, and 90-day readmissions were determined on patients within the first through third quarters of each year, so complete follow-up data were available. In an additional analysis, standard and complex cases were one-to-one matched by age group, payer, gender, obesity, diabetes, and chronic lung disease status. Patient age, Charleston Comorbidity Index, median household income, payer type, hospital characteristics, type of repair, and the urgency of repair of each patient were considered as factors potentially impacting readmission rate. A multivariable logistic regression analysis was performed using these confounding outcome variables, and the likelihood of 90-day readmissions was calculated from odds ratio, and p-values of less than 0.05 were considered significant. Our results showed a total of 203,339 patients went open ventral hernia repair from the National Readmissions Database from 2013 to 2014. 200,266 patients underwent an open standard ventral hernia repair, of which 38,313 patients were readmitted for a readmission rate of 19.1%. 3,075 patients underwent an open complex ventral hernia repair, of which 692 patients were readmitted at 90 days for a readmission rate of 22.5%. The top 30 leading diagnoses associated with readmission after ventral hernia repair are listed in this table. These diagnoses are the leading reason for readmission in approximately 50% of all readmission. Of those diagnoses, 8 are associated with postoperative infection or wound complications, as highlighted in these red boxes. After matching and weighing, 3,116 standard open ventral hernia patients were compared with 3,074 complex open ventral hernia patients. And this table shows the patient demographics that were matched and that there was no statistical significance between the two groups. This table shows the results from our multivariable logistic regression after matching. Comorbid conditions in hernia patients such as obesity and chronic lung disease were associated with a more likelihood of being readmitted, as well as older patients and those with a higher Charleston Comorbidity Index. Interestingly, those patients that had Medicaid as an insurance payer were 54% more likely to be readmitted when compared to private insurance and self-pay patients, and 82% more likely to be readmitted versus other insurance payers. Those patients that were in the lowest income quartile were more likely to be readmitted when compared to patients in the highest income quartile. Patients that had hernia repairs that were performed at a teaching hospital were more likely to be readmitted when compared to non-teaching hospitals. And finally, patients who underwent a complex open ventral hernia repair were 30% more likely to be readmitted at 90 days when compared to patients who underwent a standard ventral hernia repair. The strengths of this study include a large national data patient population to make the study high-powered with a more likelihood to show a statistical difference if present. We also examined 90-day readmissions instead of 30-day readmissions, as up to 40% of readmissions may occur after the 30-day period. Additionally, the National Readmissions Database confirms 90-day readmissions at the patient level, while other single institutional studies performed may miss readmissions in patients who are readmitted locally at their community facility or at non-index hospitals. The study may be generalizable to U.S. practices, but may not reflect practices in other countries, as patient populations and technical characteristics may differ. With this being said, there are several limitations of this study. A selection bias may be present, as the reason for complex or standard repair is unknown, the size of the defect is unknown, and outpatient or laparoscopic and robotic cases were not included. There may be a misclassification bias, as CPT codes had to be translated into ICD-9 codes, thus leaving the possibility for added variability. And lastly, there were confounding variables that were not examined in our study, and those include but are not limited to race, ethnicity, educational level, and smoking status. In conclusion, this study is the first to our knowledge that employs the National Readmissions Database to document that patients undergoing complex open component separation or myocutaneous flat base reconstruction have higher readmission rates at 90 days than those undergoing less complex ventral hernia repairs. Additionally, socioeconomic disparities, as reflected in payer status, is a particularly strong predictor of readmission in this patient population. And this data supports the concept that focused efforts and additional investigations are needed to optimize patients for more complex repairs, as well as for the socioeconomically disadvantaged patient population. Thank you.